Welcome to the alpha and beta adrenergic receptors, agonists and antagonists crash course. Here we go. The autonomic nervous system is driven by the parasympathetic and the sympathetic portions of the system. The sympathetic is our fight or flight, and the way I like to remember it is the acronym NED, norepinephrine, epinephrine, and dopamine. And I always say with a name like Ned, he was probably picked on a lot, so he stayed in fight or flight mode. Now, parasympathetic is your rest and digest, and we won't be covering that in this particular lecture. All right, so the pathophysiology of what's going on for alphas and betas is you have your presynaptic cell on the left, you have your postsynaptic cell on the right. As you know, neurotransmitters typically travel in one direction, so they're going from pre-cell into the synapse and then into the postsynaptic cell by binding with a receptor. And that's the activity what we're looking at today. Those receptors in this case are going to be alphas and betas. And I've driven you a triangle there and a quasi-rectangular rectangle to show you where the activity is occurring. All right, so the sympathetic nervous system has alphas and beta receptor sites. Those can be broken down into ones and twos. They can be broken down even further to central or peripheral. They can be broken down into selective and non-selective, but for this particular lecture, we're going to keep it pretty general. So alpha 1s typically work on the eyes, the GI and the GU sphincters, and it causes muscle contraction. Alpha 2s, at least the centrally located ones, work on the brain and the vascular system. So you will see a decrease in heart rate, a decrease in blood pressure, decrease in renal vascular resistance, and decrease in peripheral resistance. Beta 1s and beta 2s we've broken down, but typically the medication works on both receptor sites, so keep that in mind when you are prescribing medication. So beta 1s work on the heart, so you'll see an increase in heart rate, increase in contractility, and increase in AV conduction. Beta 2s really work throughout the body, and you probably want to review many different things it does in the body, but in particular I brought for this lecture was lungs. You'll see a bronchodilation, and in the liver, you'll see glycogenolysis and gluconeogenesis. The reason why that's important, let's say we're giving the medication for a heart reason. We want to drive that heart rate up a little bit for whatever reason, and let's say the patient also has diabetes. You are going to get an impact with that beta 1 and 2 action of that medication because you may be improving the cardiac situation, but you may be altering the metabolism within the diabetes. Okay. Next, so examples of medications of the agonist. So that means the medications that are giving this the action that we just discussed on the previous slide. So alpha 1s typically are decongestants. So the example I've used is phenylephrine. Alpha 2s are clonidine, guanfacine, and methyl-dopa. And since this medication is this receptor site is causing a drop in these things, in the blood pressure, for example, you want to taper that to prevent a rebound hypertension if you no longer have that action occurring. All right. Beta 1, an example is dobutamine, and beta 2 is albuterol. I like to use albuterol because you've got that bronchodilation. We're opening up those airways, and that'll be very important to look at when we look at the flip here in just a second. All right, so antagonists, or the flip, as I just referred to. Alpha antagonists, this is where we are looking at blocking, preventing, inhibiting. Let's say the medication is sitting on the receptor site and preventing the normal action. So you're going to see the exact opposite. So with an alpha 1 antagonist, the selective ones, you're going to see relaxation of GI and GU at the level of the bladder neck and the prostate. So examples of these types of medications are the Zosins, so doxazosin and tamsulosin, and these are perfect for BPH because we want to open up those vessels. You want to use caution in volume depletion, and you also want to note that it does cause fluid retention. So let's say your patient has BPH, but they also have congestive heart failure. By prescribing an alpha antagonist, you may be causing great benefit for the BPH, but you may be causing problems with a congestive heart failure. So you need to look at the entire clinical picture. All right, looking at beta blockers, or the OLOLs. Keep in mind, these are medications that will typically act on both the beta 1s and the beta 2s, although we've divided them out. So examples of the OLOLs are metoprolol, atenolol, propranolol. Those are a few that come to mind. So with beta 1s, the heart, you're going to see a decrease in heart rate, decrease in contractility, and decrease in AV node conduction. You'll also see a decrease in blood pressure due to the fact that we are reducing the release of renin. All right, beta 2s in the lungs, you're going to see increased airway resistance. The reason why that's so important is that would be dangerous for a patient with, let's say, asthma or a respiratory condition. So in the case of a beta blocker, you might be giving it to them for their heart to see if we can decrease that workload. However, if they also have asthma, you may be causing them airway problems, which could be very, very dangerous. Also, you want to taper these medications, especially in patients with coronary artery disease. All right, and the last thing I wanted to cover was combined alpha and beta adrenergic antagonists. So these are medications that work on both the alpha and beta sites, but also are blocking the effects. So examples of these would be Coreg, the carvedilol, and then the labetalol, the normodyne. These are very beneficial with patients, for example, that have congestive heart failure. So mechanisms of action, you're going to see vasodilation. We've seen decrease in peripheral resistance, thus a decrease in blood pressure. However, on the flip side, you may have a potential for orthostatic blood pressure. So the overall effect, though, is you're getting decreased myocardial oxygen demand and decreased cardiac workload. And these are my references, and I hope this crash course was helpful.